Hello, everyone. Welcome to Full Code Medical Simulation. This is Dr. Nissen, hospitalist. I practice hospital medicine, but I enjoy doing these full code cases. Keeps me up to date on emergency medicine and getting ready for rapid responses, code rescues in the hospital. And it reinforces the thought process for these scenarios. So let's get into it. We'll do play case, all cases, and we will do case 1, 2, 3, 4. Unstable with chest pain and sweating. We'll play that. All right, EMS report. 49-year-old female reports severe substernal chest pain for the past hour. She's diaphoretic and pale. Triage nurse, substernal chest pain, diaphoretic, pale appearing, unstable vitals on arrival. Direct to resuscitation bay. We'll begin. All right, and the patient, 49-year-old female patient, presents with crushing substernal chest pain radiating to her neck and jaw on the left side. These symptoms started 1 hour ago during a business meeting, at which time she left the room and became diaphoretic and pale. She reports nausea and lightheadedness after the onset of the chest pain. She has had mild shortness of breath. 1 week ago, she had a similar episode of chest pain that lasted about 15 minutes while she was exercising at the gym. Reports that this prior episode resolved spontaneously. Past medical history: type 2 diabetes, hypertension, chronic low back pain. Medications: metformin, hydrochlorothiazide, lisinopril, aspirin, ibuprofen. Allergies: no known drug allergies. Family history: non-contributory. Social history: no tobacco or alcohol use, and no illicit drug use. So we can go through review systems, and we can just click through all of them. There we go. And review systems: positive for chest pain, shortness of breath, exercise intolerance, shortness of breath, nausea. And that's pretty much it. Exam, rapid assessment. She's uncomfortable, appearing, diaphoretic, and moderate respiratory distress, GCS 15. And I want to try and do this the best I can in regard to primary assessment, which is your A, B, C, D, E, airway, breathing, circulation, disability, and exposure. Airway is intact, bilateral breathing's clear, and thready peripheral pulses, slow capillary refill. And then vital signs: tachycardic, hypoxic, and hypotensive. And also part of the primary assessment is EKG and blood sugar. And EKG shows large, so the interpretation says large ST elevations in the precordial and lateral leads. Here we see STEMI in V2, V3 only. V1, V2, these are your anterior leads. V3, V4 are your septal leads. V5, V6 are your lateral leads. So this is an anteroseptal STEMI. Here we have a PVC, and we're in sinus rhythm here. So, okay. So let's stabilize the patient for primary assessment. We'll give the patient oxygen. And this is concerning for cardiogenic shock. And you always have to be careful with STEMIs because sometimes it can be cardiogenic shock, and giving them too much IV fluids can be a bad thing. We can do a 500 ml bolus. Let me try that. We can do a second IV, put that in. Okay, so secondary assessment. We will do the workup. So chemistry, type and screen, calcium coags, CBC, lactates. We'll get liver enzyme levels, proBNP, troponin, and other labs we don't need. Imaging is just going to be chest x-ray. Oh, I think POCUS. We need POCUS. Aorta, cardiac, and lung. So let's do that. Oh, sorry. She's still hypotensive. So let's address that. So let's do norepinephrine drip. Let's add that because that's a first line treatment. First line vasopressor for cardiogenic shock. Okay. Good. And then following up the secondary assessment, B lines diffusely, consistent with pulmonary edema. POCUS of the heart. The EF is severely depressed with anterior hypokinesis. Aorta is fine. Chest x-ray shows bilateral pulmonary edema. Oh, let me see. Oh, I didn't do the I didn't do the physical exam. I keep forgetting to go back and do that. So next shows JVD to the angle of the jaw, tachycardic, regular rate, rails to auscultation bilaterally, diaphoretic. So all this is consistent with cardiogenic shock. And helpful clues to tell you this is cardiogenic shock is if you have a patient that's in shock and they're cool to touch, they have a little bit of mild pallor, thready pulses, and delayed capillary refill, which I saw here, slow capillary refill. Those are all signs consistent with cardiogenic shock. The biggest being if they're cool to touch. That tells you that it's cardiogenic shock. Troponin is elevated, 0.22. ProBNP 2045. Lactate is 2.9. Bicarb 17. B1's 25. Glucose 221. Okay. Interventions. We did norepinephrine. Now we're going to do aspirin, atorvastatin, clopidogrel, heparin drip. And I think that's it for now. Let's do that. Aspirin, atorvastatin, clopidogrel, heparin drip. And then let's reach out to cardiology stats. Let's do a stat consult. And cardiology says, I'm concerned about this patient's EKG changes, but can't take them to the catheterization lab because I've got an ongoing case that will take me at least another 90 minutes to wrap up. In the meantime, I recommend considering pharmacological options if there are no contraindications. So that would be TPA. So let's give that. Let's do cardiac. TNK bolus. And I'll just read this. I like to read this. Tenecteplase is a type of TPA that has an increased length of action compared to alteplase. It is primarily used in STEMI for situations in which cardiac cath cannot be performed or is unavailable. It can also be used in acute ischemic stroke and pulmonary embolism, but typically alteplase is used for the first line for these conditions when available. All right, so we'll give TNK. And look at that, the patient's sitting up, looks a lot better. Okay, good. All right, so we'll hand off. We'll go to ICU, and differential. It's gonna be STEMI or acute pulmonary edema. Yes. There it is. Myocardial infarction. Myocardial infarction is an injury of the cardiac tissue caused by severe narrowing or blockage in a coronary artery. It is the medical term for a heart attack. So we'll put that, hand off, and we'll finish. Yay! 100%, that's awesome. Wow. So diagnosis was myocardial infarction, dispositions ICU, stabilizations, insert IV, monitors second IV. This patient needs IV access, multiple IV access points. Monitor is crucial for patients with chest pain and non-rebreather mask. And investigations, EKG, chest x-ray, POCUS of aorta, cardiac lung. Ultrasound of the aorta. Assessing for aortic dissection is reasonable in this patient. However, if suspicion is high, ultrasound does not definitively rule out this condition. POCUS for the heart. Look for pericardial effusion, wall motion abnormalities, and estimated ejection fraction. Ultrasound lung, you can look for pulmonary edema. And then other labs, BNP, blood type and screen, coag, CBC, proBNP, and troponin. And then interventions, we did norepinephrine drip, aspirin, heparin drip, tenecteplase, and clopidogrel. And then, all right. And communication is with cardiology, obviously. All right, so we'll do detailed discussion here. This patient presents with an acute ST elevation myocardial infarction, STEMI, needing emergent stabilization for cardiogenic shock and thrombolysis. Given this patient's concerning history suggestive of myocardial infarction, MI, the initial diagnostic and treatment phase should include obtaining an EKG immediately, establishing IV access, and placing the patient on oxygen and cardiac monitor. Perform a focused history and physical, looking for signs of heart failure, pulmonary edema, and cardiogenic shock. In addition to obtaining a troponin and proBNP, other labs include CBC, Chem7, and a coagulation panel. Stat portable chest x-ray shows pulmonary edema. EKG confirms a large anterior wall. ST elevation MI. Aspirin should be promptly ordered unless there is concern for aortic dissection. While a dissection in the aortic arch can present with ST elevations, these are more commonly in the inferior leads from RCA occlusion than in an LAD distribution, which this patient has on EKG. Heparinization should be started 60 units per kg bolus, followed by 12 units per kg per hour drip. This patient's hypotension is consistent with cardiogenic shock, and vasopressors should be started after a small IV bolus of 250 to 500 cc bolus. A larger bolus could cause worsening heart failure. If a bedside echo is ordered, it will confirm poor LV squeeze, no pericardial effusion, and no bowing of the right ventricle. Cardiogenic shock should be managed with norepinephrine in combination with the bolus and infusion of normal saline, as volume overload and pulmonary edema can worsen with overaggressive volume resuscitation. If nitroglycerin is given, sublingual or IV, blood pressure would drop, potentially precipitously, and heart rate would spike. If beta blockers are given, the patient would have worsening decompensated heart failure and could potentially arrest. Dopamine infusion can increase risk of dysrhythmia. If cardiology is unable to take the patient for catheterization, the focus should be on screening and consenting the patient for emergent thrombolysis with tenecteplase bolus. Weight-based 30 to 50 milligrams bolus over 5 seconds. While alteplase is a reasonable choice, T&K is easier to administer and has a slightly better side effect profile. After lysis, the patient may have runs of wide complex idioventricular rhythm from reperfusion. Neither electrical cardioversion nor antiarrhythmics are indicated since this is normal after successful reperfusion. Pain-free and lowering of the ST segment by 50% or more. This patient should be admitted to the ICU for ongoing management of cardiogenic shock and delayed diagnostic catheterization. All right, so that's the case. Here it's listed as case number 2, with diagnosis being acute anteroseptal STEMI. Treatment includes aspirin, clopidogrel, heparin drip, a statin medication, and for treatment of cardiogenic shock, you do small bolus of IV fluids with normal saline and norepinephrine drip. And then if cardiology is not available for stat heart catheterization, tenecteplase bolus is indicated. And we admit this patient to the ICU for ongoing management and delayed heart cath. I think that's pretty much it. If you guys have any questions or have suggestions for future videos, let me know in the comments below. And I'll see y'all in the next video. Bye-bye.